All right, so welcome back. So in this part, we're going to talk about some specific types of cutaneous mechanoreceptors. So if you recall, mechanoreceptors are those that are responsive to actual physical mechanical stimuli that in some way pull, push on, distort the actual nerve endings of the dendrites that then allow a signal to be sent back to the central nervous system, right? So the first one we're going to talk about are free nerve endings. So free nerve endings are what are known as unencapsulated receptors. So meaning they do not have any connective tissue capsules surrounding the outside. These are relatively simple in structure. They generally come and arise from the dermis. So most of these that we're going to talk about here in this this part of this lecture are going to be found within the skin. So these are going to arise from within the dermis, extend up into the epidermis, and then just end in the epidermis, where any type of external stimulation would, or external stimulus would then stimulate those free nerve endings. So they can range from slowly adapting to very rapidly or very quickly adapting. They can respond to temperature, they can respond to touch, they can respond to pressure. This is also the basis of our tickle sensation, and so you'll know that tickle sensation is really, it's thought and perceived by most people as being a pleasurable sensation, but you know it has to be initiated, or it has to come from somebody else. So you've noticed, or if you haven't noticed, you should. You cannot really tickle yourself all that effectively. This is because the brain needs to, it cannot have the same body that is receiving the sensation also be providing the stimulus. So in other words, you have to have somebody else providing the stimulus. They have to be the one that are actually doing the tickling, and then the individual can sense that stimulus, and then they're able to perceive it. Okay. So the second one that we'll talk about are called Merkel's cells. These are also sometimes referred to as tactile cells or tactile discs, and these are fine touch and pressure receptors. Okay. These are located throughout different areas in the skin, generally in the deeper layer of the epidermis, so in that stratum basal that we have discussed in previous integumentary system lectures. These can respond to the kind of presence of a constant stimulus that is pushing on the receptor and providing some type of physical and mechanical stimulation. So because they respond to this kind of constant pressure, they're going to be known as slowly adapting. So if you recall in the last part, we talked about tonic and phasic receptors. These are going to be considered a tonic receptor because they continually respond to this constant stimuli. Okay, they generally have small receptive fields, meaning that one Merkel cell or one sensory unit covers a very small section of skin. So that small receptive field that we talked about in the previous part. There are also ones known as Meissner's corpuscles. All right, these are sometimes known as tactile corpuscles as well. These are going to be located deeper within the dermis of our skin. They're going to respond to fine touch and pressure, along with vibrations or low frequency vibrations. Okay, these are generally found in fingertips. They can also be found on our lips. They're found in areas of glabrous skin or glabrous skin. This means skin that does not have any hair. So think about on your own body, where are areas of skin where you don't have any hair? Well, these areas are like our palms of our hands and soles of our feet, along with our digits as well. These areas do not have any skin. Or they have skin, they do not have any hair. These receptors are also rapidly adapting. So if you think back to our last part, these are going to be known as phasic receptors. So they adapt to that constant stimulus relatively quickly, so within a second or so. And again, these are responding to some type of pressure or light touch or vibrations. Okay. The next one are known as Ruffini corpuscles. Okay, these are sometimes called bulbous corpuscles as well. These are deep within the dermis, and they're responding to the distension of the skin or the stretching of our skin. All right, so these are what are known as encapsulated. And if I go back one, these Meissner corpuscles, these are referred to as encapsulated nerve endings. Okay, so encapsulated meaning that they have a connective tissue sheath or this kind of collagenous connective tissue wrapping around the outside of it, and then contained within that connective tissue sheath of this collagen, of these collagen fiber, is the actual nerve ending, so those dendrites. So stretching of the skin or pressure, whatever it may be, distorts that collagen capsule, that collagen sheath around the dendrites, around those nerve endings. And so once those are distended or distorted, it then pulls and stimulates the fibers, and then the stretching and distortion of those nerve fibers or those dendrites then allow a signal to travel back to the central nervous system, and then ultimately to the postcentral gyrus or the somatosensory cortex, where we then are able to perceive that as some type of pressure, or in this case, maybe stretch. Okay, these are going to be tonic receptors, or they're going to show little adaptation or adapt very, very slowly. Okay. All right, the next one are known as Krause's corpuscles. These are also encapsulated. So if you notice here, they have this connective tissue capsule running around the outside. And these are responding to certain temperatures, like very cold temperatures, and we'll talk about other types of thermoreceptors here briefly, and also different types of pressure as well. Okay, so these can be found in areas of dry skin along with mucous membranes. Okay, so like mucous membranes of our mouth and other internal areas. All right, the last one is known as a Pacinian corpuscle, and this is a very encapsulated mechanoreceptor. You can hopefully very easily appreciate the encapsulation of this receptor. You see all of these concentric rings. This kind of looks like a section of an onion, is how it's sometimes described. And then running through the middle, or through the core, you have this one single sensory ending, right? This nerve ending, or this dendrite here. And so this is responding to deep pressure. It's also responding to low frequency vibration. And these are rapidly adapting. So anytime you have some type of pressure be applied to the skin, so again, this is in the skin, this is in the dermis, glabrous skin, like we mentioned earlier with Meissner's corpuscles. But as you apply pressure or some type of vibration onto the skin, those vibrations or that pressure is going to distort this connective tissue capsule, so these collagen fibers, the sheath here. And as you distort that sheath and you push on it and you vibrate it and you apply pressure, it's going to then move and distend and apply a pressure and stimulate the nerve ending. And then again, the nerve ending is going to generate an action potential back to the central nervous system, to our somatosensory cortex, and then we perceive it. Okay, these are also very rapidly adapting, meaning they can respond very quickly, and then after a prolonged stimulus, this prolonged stimulus that is present in the environment, they stop responding. It relieves the pressure, and they stop generating those action potentials, so you stop perceiving this sensation of pressure or vibration. Okay, so there are also different types of thermoreceptors. So we talked about thermoreceptors a little bit earlier, and so there are different types of thermoreceptors, and they vary based on the temperature at which they open or which they respond to. So if you notice this area down here, these are responding, all these are different types. So this TRP, this is a transient receptor potential cation channel, okay? Meaning, if you recall, a cation, that is a positively charged ion. So in this case, we're referring to calcium. And at different temperatures, these cation channels will open, allow ions to flow in, and depending on which channel opens and what type of ion and how many ions flow in, we then perceive that as being a cold temperature or a warm temperature or a medium, kind of a moderate temperature. As we mentioned earlier, there are anywhere from 3 to 4 to 6 times more cold receptors than warm receptors. But we said earlier also that the actual structure of the receptors doesn't really change a whole lot, but it's more so the temperature at which they respond to. Okay. Now, one important thing about temperature and thermoreceptors is that we generally don't perceive temperatures below 10 degrees Celsius. So this is about 50 degrees Fahrenheit or so. Okay, so around 50. Beyond this, or below this rather, the cold temperature actually serves as an anesthetic. So this is where we're at, this area right over here to the right. So this is why we apply ice. We apply cold temperatures to injuries, to bruises, to cuts, whatever it may be. because it serves as an anesthetic, it serves as an analgesic to stop the pain sensation, so we stop perceiving the pain. All right. So we know we can also apply ice for things such as inflammation, and in this case, the ice serves to help with swelling of the. So say you rolled your ankle or something, you can apply ice. This helps with the swelling, but it's also helping with our perception of pain as well. So you've heard of the RICE method, the rest, ice, compression, and elevation. The I in the RICE method stands for applying ice or applying something cold to that injury to reduce the swelling, so to prevent and reduce inflammation, but it's also helping to ease our pain as well. So you also know if you've ever been in an ice bath or you've been in a very cold environment, after a while you may say that your fingers are numb, or if you're in an ice bath kind of below the water line, all your body below that is considered to be numb, right? You don't feel it. This is because our body, we do not perceive temperatures below 50 degrees whenever they're stimulating our different types of thermoreceptors, okay? When it comes to pain here, when it comes to temperature here, these thermoreceptors are generally rapidly adapting. So they're typically phasic receptors. And you know this if you walk into a room that is a very significant difference from the location you just came from. You notice it initially. So you're outside and it's very hot. You walk into your air-conditioned house or room. You notice that temperature difference, but after a while you stop noticing it, right? And even if you're in one room itself and somebody starts slowly changing the temperature, you're probably not going to notice it unless there's a significant change in the temperature at once, okay? So this goes down to this idea that these are going to be adapting very rapidly, very quickly in the presence of a constant stimulus or a constant temperature, all right? So for our pain, so for nociceptors, we've talked about this a few times. These are going to be generally very slowly adapting or very limited adaptation. And as we said earlier, this is a good thing, right? We want to be able to continually noticing a painful stimulus because this is a protective physiological mechanism, right? And so we have different types of pain based on the duration of the pain and based on how quickly that pain stimulus reaches our central nervous system. So these are our different types of pain. We have fast pain, slow pain, acute pain, and chronic pain. So fast pain means that this is pain that from the onset of the stimulus, so as soon as you have the stimulus and that stimulus is transduced into an action potential, it reaches our central nervous system very, very quickly. Okay, so this is fast pain. This is typically what we think of as sharp pain or prickling pain, something like that. Okay, there's also slow pain. Slow pain is typically categorized more as burning or aching or dull or throbbing, right? This can be felt in different types of tissues, whether they're superficial or deep. Now, the difference between these two and why we perceive some as being sharp and prickly or some are being dull and throbbing and burning and aching is based on the type of nerve fiber that transmits these signals. So there are certain fibers that are called type A fibers. Type A fibers are very, generally, they're very large and they're myelinated as well. And so these send and propagate signals very quickly, very, very fast. So if you remember, myelinated axons propagate action potentials much faster than unmyelinated axons, right? So these are sending signals very, very quickly, whereas slow pain is typically being transmitted and propagated along what are called type C fibers, okay? So type C fibers are typically smaller, and they are also typically unmyelinated, right? So this signal is going to travel slowly, so you get more of a burning, you get more of a aching, dull, throbbing sensation, okay? Now, you also have types of pain based on the persistence of that pain. So acute pain versus chronic pain. So acute pain happens very, very quickly, and it does not last very long. Generally, as soon as the stimulus is present, and then as soon as it is removed, that pain signal generally stops. Chronic pain is more persistent, right? It's more chronic, hence the name. So this is generally something like back pain, right? So if we think of acute pain, if you're walking and you step on a sticker, or you step on a Lego, or you step on something sharp, you feel it very quickly, right? It hurts immediately. You retract your foot, you withdraw it, you have a reflex. but that pain's probably not going to continue. You're not going to continue perceiving that, 5 hours later or the next day or the next week, right? It was very acute. It happened very quickly. And then as soon as you remove the stimulus, the sticker, the Lego, whatever you stepped on, that pain stops. Whereas chronic pain is going to continue. So if you've ever had a back injury, you know that back pain lasts it can last a very long time, right? So it may last a number of weeks, a number of months, depending on the severity. If you had a back injury, it could last a number of years, right? And so this is going to be very dull, very chronic. It is going to continue for a very long time, all right? So there's also something known as referred pain. And referred pain can be it can be very important clinically, all right? So referred pain has to do with pain coming from a visceral region. So again, think viscera. We're talking about organ. This pain coming from an organ is actually perceived as pain coming from some somatic body region, right? So instead of us feeling the pain from a heart attack coming from, maybe right over the chest, you could actually feel it coming from along the arm, right? So this is a common complaint of people experiencing a heart attack. They'll feel pain in their arm. Some people actually also feel pain in their jaw as well. So the proposed mechanism for this, or what's thought to be happening, is that the sensory fibers, the sensory nerves that are coming from the visceral organ, so from the heart, from the stomach, whatever, arrive at the spinal cord at a certain level, all right? There are also sensory fibers, sensory nerves, coming from somatic regions, so from sections of skin that also arrive at that same spinal cord level. And so if you have the heart, so the heart can generally receive sensory fibers from like C, 3, 4, 5, somewhere in there, kind of middle to low cervical region. There are sections of skin that also receive sensory cutaneous stimulation, innervation from those same areas. So pain from a heart attack, that sensory information is coming back to the spinal cord. At the same level, we have somatic sensory information coming from the arm, and they relay at the same part of the spinal cord. And so sometimes our brain can perceive that pain coming from the heart as actually coming from that section of skin. So this is why somebody may complain of arm pain or jaw pain during a heart attack, right? The pain's not coming from their arm. They're not having problems with their arm. They're not having problems with their jaw. They're having problems with their heart, but it's being perceived as coming from one of these somatic body regions, okay? So here's another example showing something like a kidney. So sensory neurons from the kidney come into one section of the spinal cord. Sensory information coming from a section of skin come into the same area, and you could perceive it as being pain from that somatic region, right? So this is a chart that shows commonly referred areas or areas of referred pain depending on which organ. And so you could see heart, you may feel it in the chest region, but there's a chance you could also feel it along the inside of your left arm down into your hand, right? Lots of our digestive viscera you feel in different areas of the abdomen. Different areas you may also feel in the area kind of in the low thorax or upper abdominal regions as well. Okay, so it's very interesting. There's another phenomenon known as phantom pain or phantom limb pain. This has to do with pain from a specific area of the body when that area of the body has just been removed. So say there was somebody with severe diabetes, right, and they had to have their part of their leg amputated. So say from below the knee or maybe right above the knee, they had to have that amputated, or there was a burn or trauma or something. What can happen is a patient who maybe just had their left leg removed above the knee may be complaining of leg pain after their surgery, right? Well, you may think well, that's strange. How can you have leg pain if you don't have a leg? And what's happening is that although you may not have your leg or you may not have your foot or your shin or something, you still have more proximally, you still have sensory fibers coming into the spinal cord that were previously coming from that area of the foot, right? So it may have been amputated just above the knee, but you still have fibers in your thigh that come up to your spinal cord that were coming from your foot or coming from your lower leg, right? And so you can still perceive pain coming from those areas even if you don't have that limb anymore. So it's very interesting. You still treat pain, this phantom limb pain, you still treat it like real pain. So in a clinical setting, you still treat it like real pain. And one thing you'll learn about pain in future classes and as you continue forward in your education is that pain is incredibly subjective, right? So we all know this, right? What hurts me may not hurt you. What hurts you may not hurt me, or to varying degrees, right? So in a clinical setting, you treat what the patient is complaining of, right? If they're saying something hurts, whether you believe it or not, whether you think that would hurt you or not, you're treating that patient's pain, right? Their subjective perception of the pain, all right? So the way we get the pain signal from the periphery, so say we step on something or we poke something with our finger, the way we get it from the periphery to the brain is through a pain pathway or a sensory pathway, all right? And there are different kinds of pathway that transmit specific types of information. So there are specific pathways that transmit pain information. There are certain ones that transmit touch and vibration and pressure. So for this one, this is known as the spinothalamic pathway, right? And we'll look at the spinothalamic pathway in just a second in more detail. But in general, for these pathways, for these sensory pathways in general, they consist of three parts or three neurons. There's what's called a first order neuron, a second order neuron, and a third order neuron, all right? So the first order neuron is coming from the periphery. It's coming from your foot. It's coming from your chest. It's coming from your hand, right? Somewhere in the periphery. It sends that signal, that pain signal, okay, in this case we're talking about pain, that painful signal from the source, from the sensory receptor, along a sensory or afferent neuron into the spinal nerve, into that posterior or dorsal root, and into the dorsal horn, right? Remember this dorsal root ganglion? This is where we have our sensory cell bodies, okay? So remember we said in previous lectures that when you think of the dorsal root, the posterior root, dorsal horn, you should think of sensory information or afferent information. So here we have afferent fibers coming in, into the dorsal horn, into the dorsal root. We synapse with this small interneuron, and then from this we go to what is called a second order neuron, right? So this long one here, this is a second order neuron. Now what happens, and you may notice it here, is that we had information coming in on one side of the spinal cord, but then it crosses over, okay? So this process of crossing over, we have a signal from one side coming over to the opposite side. That process is known as decussation, okay? Or the neuron is said to have decussated, all right? So here we had a first order, synapses with a small interneuron, and then it decussates over, the second order decussates over into what is called the spinothalamic pathway, okay? And this is specifically, you'll learn, and we'll talk about it later probably, but this is specifically the lateral spinothalamic pathway because this is transmitting pain and temperature, right? So here's a pain stimulus. We're now in this lateral spinothalamic pathway, and we can ascend through the spinal cord, through the medulla, all the way up the brainstem, to a region known as the thalamus, all right? The thalamus is essentially our sensory information relay station. So any senses that are going to reach consciousness, besides our sense of smell, has to pass through the thalamus, all right? So we've gone from the periphery to the spinal cord, we decussate, we go up the spinal cord, through the medulla, through the brainstem, to the thalamus, then we synapse here in the thalamus, and now we have our third order neuron, which travels to this blue region here, which is called the post-central gyrus. That's the structural area, and the functional area associated with the post-central gyrus is known as the primary somatosensory cortex, right? And we then perceive this as, in this case, pain from the finger, okay? Now, we'll see in a little while that specific parts of the body are mapped to a specific part of this post-central gyrus. So in other words, pain sensation from the finger goes to one region, whereas pain sensation from the foot will go to a different region, all right? So this has to do with the organization, the topographical organization of the post-central as well as the pre-central gyrus, okay? So we will stop here and we will pick up talking about ways to modify pain with different medications in the next part, and then we'll finish talking about different types of sensory pathways.